Welcome to Around the Rheum, brought to you by the Canadian Rheumatology Association. This episode has been made possible in part by Boehringer Ingelheim. Thank you, Boehringer Ingelheim, for your generous support in sponsoring this episode. The scientific integrity and objectivity of all podcast content is overseen by an independent CRA committee to ensure the highest standards.
Over the past 10 or so years, we're recognizing that they're probably much more common than we previously believed. Many of them are not monogenic. Many of them are adult onset. And a lot of them have chronic symptoms rather than episodic symptoms. But I will say that the classic definition certainly applies to autoinflammatory diseases, but only to a very specific subset, which are the IL-1 or inflammasome-mediated diseases. But a lot of the other autoinflammatory diseases can certainly stray outside of that traditional definition.
That's Dr. Jason An, a Toronto rheumatologist specializing in autoinflammatory diseases. He completed his rheumatology training at McMaster University and a fellowship in genomics and rare diseases at Sick Kids in Toronto. He's our guest on this episode of Around the Rheum for a conversation on autoinflammatory diseases. Welcome to everyone who's listening. I'm Daniel Ennis, and I'm joined by my co-host, Dr. Janet Pope. Hi, Janet. How are you doing?
Great. How are you, Daniel? I heard you were at a great World Vasculitis meeting.
Yeah, so I just got back from Australia a week or two ago, and the meeting was really great, and lots to learn there. I don't think you have this experience, but I am always humbled when I go to conferences by how smart everyone else is. I think you're one of those people who's humbling everyone at the conferences.
Not in vasculitis, though, Daniel. That's your set.
So very nice to see you. So let's get to our guest. That's Dr. Jason An. Welcome to the show. Thanks for joining us.
Thank you very much for having me. It's a pleasure to be here.
The pleasure is ours. Maybe just before we get into the main conversation, I'd love if you could just give listeners a little insight into your particular areas of interest or research. What is the focus of your practice?
Apart from doing regular rheumatology, I have a big interest in autoinflammatory disorders, and that's been my major focus for the past 5 years. So I have a couple of clinic days dedicated specifically to that. I'm very involved in research as well, with growing a couple of my own cohorts and trying to understand more about these different genes that are associated with autoinflammation and how they may be different in children versus adults. I'm also quite involved in education. I have a couple of students that work with me, and I have some trainees as well that come to my clinic, and so they keep me on my toes.
That's great. There aren't to my knowledge, a lot of adult rheumatologists who have kind of the expertise and kind of crossover knowledge about these autoinflammatory diseases. And I think we're going to talk about it, but these aren't only pediatric diseases, they are also adult diseases. It's not just pediatric patients with the disease growing older. Some people develop these diseases in adulthood as well. And you articulated that really nicely in a paper that we'll talk about in a little bit. Before we go further, could you remind me what sort of the fundamental difference is between an autoimmune disease and an autoinflammatory disease?
So that's a good question. And I think as we understand more and more about immunology, this sort of arbitrary distinction between autoimmunity and autoinflammation becomes increasingly blurred. So I think if you were to look at any textbook, they would tend to describe an autoinflammatory disease as something that is extremely rare, monogenic, childhood onset, usually presenting with recurrent fevers and other types of episodic inflammatory symptoms. On investigations, they tend to have a very elevated CRP and the absence of autoantibodies, and also the absence of autoreactive T cells. And I think exactly as you pointed out, Daniel, is that over the past 10 or so years, we're recognizing that they're probably much more common than we previously believed. Many of them are not monogenic. Many of them are adult onset. And a lot of them have chronic symptoms rather than episodic symptoms. But I will say that the classic definition certainly applies to autoinflammatory diseases, but only to a very specific subset, which are the IL-1 or inflammasome-mediated diseases. But a lot of the other autoinflammatory diseases can certainly stray outside of that traditional definition.
You wrote a really great expert review in Rheum in July 2024 that outlines a lot of your approach to autoinflammatory diseases. I was hoping that you could walk us through the main classes. How do you group or characterize these diseases? Because I'm sure that you see this all the time. Adult rheumatologists have a pretty vague scaffolding for these diseases. They think, oh, autoinflammatory diseases, people with conjunctivitis and people with stomach pain, and we sort of trip over our feet even trying to group them. Can you give us a little bit of organization there?
Yes, autoinflammatory diseases it's a growing field, and it is a relatively new field within the umbrella of rheumatology. And so there isn't one specific classification criteria that everybody uses. So everywhere you look, there's going to be a slightly different way that people classify autoinflammatory diseases. But I think if you look at all of these different systems, they tend to have a couple of things in common. So either they're classifying them according to cytokines, or it could be classifying them according to pathways and other types of subcellular components and organelles that are involved. The one that I usually use is cytokine-based, and there tends to be around 4 major buckets that we can put all the different autoinflammatory diseases within, and at this point there are close to 100 of them. So the first bucket is the one that I think most people are more familiar with, which is the interleukin-1 bucket. And these are the inflammasomopathies. The classic example would be familial Mediterranean fever, but also things mevalonic kinase deficiency as well as cryopyrin-associated periodic syndromes. Another bucket would be IL-18, in other words, those associated with macrophage activation syndrome. These patients also have a significant interferon gamma signature, and as I mentioned, they tend to present with macrophage activation. Another bucket, the third one, is to do with TNF and NF-kappa B signaling. And so the clinical presentations for these patients can be quite varied because the NF-kappa B pathway is very ubiquitous and it's expressed in many different cell types. And these types of patients can tend to present with more of a Behçet's phenotype, but they can also have other aspects of dysregulated immunity, including immune deficiency, atopy, lymphoproliferative disease, as well as autoimmune disease. And then the last bucket are the interferonopathies. And so these patients have sort of abnormalities in the handling and the metabolism of nucleic acid. And certain examples of these disorders would be Aicardi-Goutieres syndrome, which tends to happen in children, but also monogenic lupus, which many of us adult rheumatologists could be seeing in our offices as well.
You had listed, there were a couple other ones in there that I thought were so interesting because you included cytoskelopathies and enzyme deficiencies on your list in your article, which when I see a whole category of diseases that I'd never heard of before, brings me some degree of shame that I wasn't aware of that. But that is really helpful for kind of broad structure.
So I think there is a lot of overlap between all of these different buckets.
Mm-hmm.
And the cytoskelopathy, which you mentioned, I would say is you can think of it in a different sort of classification system where we're looking at different cellular subtypes. I guess to take a step back, when I reflect on my own training, I feel like in internal medicine, we spend a lot of time learning about how the different organs function and how they talk to each other and what happens when the organs don't work properly. But in autoinflammatory diseases, I think we learn a lot about how the organelles function and how the different subcellular components work with each other, particularly in the immune cells. And particular components that are important, which could be part of a different classification system, would be disorders that are associated with the inflammasome, disorders that are associated with the ER-Golgi complex, with the mitochondrion, with the nucleic acid, as with the cytoskeleton, which is extremely important in the regulation of immunity, as well as other things like the proteasome. But there are a lot of overlaps because, for example, proteasome disorders tend to be interferon disorders, and cytoskeleton disorders can certainly have a large IL-1 component to it as well.
So I'll ask a question. So I'm going to call this rheumatology question for the not as informed, because I do think of these things at times, but I don't always even think of the whole classification. So if there was a kid with that recurrent focal sterile osteomyelitis and they have different initials now, they change them up sometimes, and I had an adult with SAPHO, would they be in the same bucket? Is it the same sort of mechanisms that are causing osteitis in an adult as we'll call it sterile osteomyelitis in a kid?
So I think it could be. It's difficult to say because I think the phenotype, I think there are different ways to skin a cat. And there could be many different ways to arrive at that particular phenotype. If the phenotype you're describing is recurrent fevers and sterile osteomyelitis, I think what we're dealing with is it's a phenotype. And that phenotype is the end result of many steps of dysregulated immunity that start with a combination of genetics and environmental triggers. And so I think the combination of genetics and environmental triggers is probably different in those two different individuals. If it's onset in children, then it probably means that the genetic component is stronger. In other words, the probability of it being a monogenic disease is higher compared to the adult. But I would say that a lot of adults with these types of presentations could also be monogenic because many of them have actually had onset in childhood, but it's just been missed for a number of decades.
To kind of discuss the classification further, so as you said, there's different ways of approaching it. I guess I'm wondering about in clinic, how do I access that sort of classification or categorization? Because I guess I'm seeing a clinical syndrome, and I have to work backwards from that to what I think the pathophysiology is. When you classify them the way that you've described, do those categories produce relative similarity in terms of clinical phenotype? Can you look at someone and say, this is an interferonopathy pattern or phenotype, this is an NF-kappa B pathway phenotype? Are you able to do that clinically?
Yeah, so that's one of the things that I put a big emphasis on in terms of teaching my trainees in clinic is pattern recognition. And between the four different buckets, so namely interleukin 1, interleukin 18, TNF, and interferon, there are definitely, there's overlap, but there's also distinctions between these four buckets. For example, patients with interleukin 1 disorders tend to present, if you think about FMF, they tend to present with recurrent episodic attacks of certain symptoms, usually high fever, serositis. They can have rashes. The rashes tend to be more like hive-like rashes. They can resemble hives, but they are not hives in the sense that they last longer. They are not particularly itchy. They're more burning and painful, and they don't respond to antihistamines. And usually by the time that they see you, they've probably seen an allergist. And part of the story tends to be that the allergist doesn't think that these are typical urticarial hives. They also have serositis, and that can happen in different organs, so it doesn't have to be recurrent abdominal pain. Many of them can have a history of pericarditis or myopericarditis. When you look at the investigations, their CRPs tend to be quite high during the episodes. Sometimes it can be high in between the episodes, but certainly in the episodes, it tends to be very high. And they also respond very well to colchicine, and they respond very well to IL-1 blockers. So that's the IL-1 bucket. The IL-18 bucket comprises a number of different disorders, but as I mentioned, they tend to present quite severely with macrophage activation syndrome. That's sometimes how they first come to attention, but they could in the background also have other types of chronic inflammatory problems like inflammatory bowel disease or lung disease, arthritis, and rash. The third bucket, which is the TNF-related syndromes, which we like to call the NF-kappa B-opathies. I tend to think of these as Behçet's phenotype. So if you think about a patient with a predominantly mucocutaneous type of involvement, they could have recurrent fevers, but they tend to be more of a chronic grumbling type of presentation with intermittent worsenings. These patients fit more into the NF-kappa B type of disorders. Now, as I mentioned, the clinical heterogeneity can be extremely wide and variable. One of the poster children of the NF-kappa B-opathies is a haploinsufficiency of A20. And as you may be familiar, there are a huge range of clinical phenotypes associated with haploinsufficiency of A20, ranging from skin to joints to eyes to guts. And they can also present with immune deficiency and atopy and organ-specific autoimmunity as well. And then finally, the interferonopathies. Think of your patients with lupus. So these patients can certainly have autoantibodies and autoimmune features, but they tend to present with perhaps chronic fevers or low-grade fevers. They don't necessarily have these really distinct periodic attacks like you would see in FMF. They can also get rashes as well, but they tend to be more like vasculitic rashes, perhaps more of the vasculitic types of findings on a biopsy as opposed to predominantly neutrophilic, which we see in IL-1 disorders. The CRP, if you think about your lupus patients, don't tend to be extremely high. Could be elevated, but it's not going to be in the 40s or 50s. And they, as I mentioned, they can certainly have a wide range of autoantibodies. These patients don't respond as well to colchicine and interleukin-1 blockers, but they respond quite well to JAK inhibitors.
I think that's really helpful as broad clinical correlates. So when you see someone in clinic, you can get a pretest probability at least for what you expect one of the underlying diseases is. Janet, what's your feeling about this? Does this kind of ring true for what you have seen clinically over your career?
I think so. But first of all, Jason, I think you're categorizing it in a really helpful way because there are definitely like the referrals that I would get. Some would be lupus-like, and then maybe they have more serositis than we'd expect, or no specific autoantibody, or they might be these recurrent fevers. And sometimes they do have a family history. Like I've had an uncle where one of the nephews had, I think, Muckle Wells or something, but a different niece, like not that kid's sibling, apparently had childhood onset still. So you go, wow, this family has stuff going on, but you can't put it all together. So I think in fairness, I sometimes am going by a phenotype of they're referred with, say, fever and serositis, or they're referred with recurrent rashes, maybe low-grade fevers, and they've been mislabeled a couple times and not responding to treatment. So I think what Jason's saying probably clarifies better that maybe I could have been more goal-directed, saying I think I should look for this or that, because I do find, and we will talk about it shortly, I'm sure, but I do find that sometimes the genetic testing is very dissatisfying because it says can't rule out it's heterozygous, could be associated with the clinical value of this is unknown. Like I think the kids are finding more and more genes, but I think the kids, as Jason said, are more mono, so they're a little bit more straightforward. Even if the gene hasn't been described, their brother has it as well or something. Adult onset, I always think I'm missing Where's the brucellosis or some weirdo infection that's causing this prolonged inflammatory reaction? So that's what I would say. Daniel, would you say when you get like a referral like this, because you probably get them for rule out vasculitis?
I get
You,
nervous when I get
yeah.
like a young person with vasculitis or someone who's graduated from peds who is not responding really well to standard therapies. I worry that we have missed some kind of monogenic or some kind of underlying monogenic disorder. But I have to say that I haven't really caught a lot other than a handful of data too, which have come across my plate. Maybe that's a good place to talk about genetic testing then, because it seems like a very useful tool, like many of our tests, really useful if you know what you're doing, and really useless if you really don't know what you're doing with it. Jason, can you give us a little bit of a walkthrough of kind of what's out there and how you use it in your clinic?
Yes, it's a good question. The types of genetic tests that we have available to us are constantly expanding, and which is a good thing. But I think, as you pointed out, we also have to be expanding our sort of knowledge and training on how to use these tools and how to interpret the results. The most basic genetic test that we have is Sanger sequencing, which is the sequencing of one gene. That is probably the gold standard genetic sequencing that we have. But in this day and age, in 2026, most of the sequencing that we do, probably 90% plus, is done on gene panels. And the technology behind this is what we call next generation sequencing, which is not really next generation, it's this generation. And it's quite different from Sanger sequencing. We sequence a lot more genes, but the limitation there is that there's a specific subset of genes that are on the panel. And so when we're looking for a genetic disorder, we can only find it if that gene is part of the panel. And so 90% of the time, the genetic testing that I do is the sick kids' recurrent fever or the autoinflammatory panel that's run at the Division of Genome Diagnostics at Sick Kids. But I think, as you pointed out, many times the panel doesn't reveal any particular diagnostic result. And so then we have to think about what other tests can we do. And some of the things that are also out there that we may not all have access to are things like exome sequencing. So exome sequencing covers all of the different genes, all of the different protein coding genes that are out there. It's certainly much, much broader than doing a gene panel. If we're concerned about having variants of uncertain significance come up on a gene panel, you can only imagine what happens when you expand that to all of the genes that exist in our genome. And then beyond that, there's also whole genome sequencing, which is not available clinically to rheumatologists as of yet. But this is similar to exome sequencing, but it also includes sequencing of the introns, and it also allows us to look at copy number variants, which is also an important cause of certain inflammatory diseases. But I think one important point that I'll make is that, in my opinion and in my experience, I think that a lot of the uncertain variants that we find on the panel, which are by definition not diagnostic, are probably the best explanation in those patients. And that further sequencing with exomes and genomes and long read sequencing and somatic sequencing and all those things probably actually have a very low yield. And so I think finding a variant of uncertain significance means something different when you find it in a young child versus when you find it in someone with an adult onset disease.
Can you explain that? Why is that so different? Is it just the pretest probability of it being the cause, or how do you explain that distinction?
So if a child has a monogenic disease, it means that child has a gene mutation that is almost by itself sufficient to cause disease, meaning that the penetrance is high, the effect size of that mutation is very high. it means that there aren't many environmental triggers that are necessary to bring that above the clinical threshold. And so when that happens, presumably, this is also a rare disease. And so that means the gene mutation should also be correspondingly rare. So if you think about the concept that we all know, which is that common things are common, when you look at rare diseases, the opposite is true in the sense that rare things are rare. So if you look at a patient with a rare disease, meaning that you're in the emerge, let's just say you're a pediatrician, you're in the emerge, you've never seen this before, you refer them to multiple specialists, none of them have ever seen that before, you're dealing with a rare disease. And so if there is a gene mutation that is causing that rare phenotype, that gene mutation must also be correspondingly rare. So that means most of the gene mutations that happen in children that cause a phenotype like that come from gene mutations that are extremely rare. Now, if you think about adults, that may be very different because if you have the gene mutation that is extremely rare and extremely penetrant, it should have caused disease in childhood. And so if it has only surfaced when the patient is 30 or 40, it means that the contribution of that gene mutation to the phenotype is relatively much lower, and that there probably had to be multiple other factors that triggered the pathogenesis, such as environmental triggers like stress or inflammation from infection or other sources. And also this idea that you need time, right? Because for all of these stars to align, it's a statistical event. And statistical events only become more likely with the passage of time. And so if that is the case, then when you do the genetic testing in an adult onset patient, you wouldn't necessarily expect the gene mutation to be extremely rare. It may be more common. And because it's more common, it cannot be classified as pathogenic. And it tends to be classified as a variant of uncertain significance. But that variant of uncertain significance is probably still the most important genetic contributor to the phenotype that you're seeing in front of you. And it's a similar idea to something we see every day, which is B27 positive sacroiliitis. Someone who's B27 positive is not going to have rip-roaring sacroiliitis from the day that they're born. It tends to happen and gradually, insidiously occur through the decades. To the time when you see them, they have a physical disorder. And when you do the genetic testing, and we all do genetic testing whenever we send B27, is we find an allele that is relatively common in the general population, but we will interpret that as the most important genetic contributor to that phenotype. And it's a similar idea with a lot of the VUSs that we see in adults with recurrent fevers.
That's really eloquently put. It is bad news for me, who is hoping that genetic testing would just tell me what the person has. And what I'm hearing is that I still do need to use my brain. And that's not great news, but that does make sense. That I think that model of interpreting the genetic testing is actually quite helpful. Even if you do get a variant of unknown significance, it's still of potential significance. It's not nothing, but it maybe fits better with your adult onset disorder, and maybe we're less likely to see just like the full monogenic disorder, it just been missed for 30 years or whatever. If they have seen a pediatric rheumatologist, they're probably going to catch it. So that's actually quite helpful in interpreting things.
So, Jason, when we do get, because that's when we send them, so in London, Ontario, we send them to sick kids, the genes. We get the uncertain significance. Should that help me then to say, oh, that gene would be more like an NF-kappa B pathway, or be more like an IL-18? Will that help me if I actually knew what the heck the gene meant? Or it doesn't matter because I'm going to treat on phenotype?
So I think I'll just take one step back to Daniel's point, is that I think we're all sometimes hoping for a gold standard test that would just give us the answer. And when the bioinformaticians in the lab look at the genetic data, they will report certain variants, and then they will classify those variants as pathogenic, likely pathogenic, VUS, likely benign or benign. And if they're likely benign or benign, they won't report them. And they classify these variants according to the ACMG criteria, the American College of Medical Geneticists. It's basically the equivalent of the ACR, but ACR guidelines or the CRA guidelines, but for the geneticists. And so they look at a number of different criteria, a number of different bioinformatic characteristics of these variants in order to classify them. For example, the population frequency, the in silico predictions, whether there's been any prior literature, and so on. But the one thing they do not consider is the patient's phenotype. Why? Because they are people that work in the lab. They are not clinicians. They are not seeing the patient. It is ultimately still up to us as clinicians to make that final clinical correlation. Just like how the person at the bench can only tell you the titer of the ANA, you have to assign the significance of whether that corresponds to the person's phenotype. And going on to Janet's point is that when you get a VUS in the results, you do have to make a sort of a subjective judgment as to whether you think that could be corresponding to the phenotype. And so when it's a VUS, the phenotypes allowed, quote unquote, is probably much more broad, but it still probably has to be within that particular pathway. For example, if you're seeing a patient that looks like FMF, in other words, you have an IL-1 type of phenotype, but then you get an interferon VUS in your report, then probably that's not going to be related. And so you would probably still have to treat that person according to the phenotype, right? In the same way that we would never just treat a lab result, we have to treat what the patient actually presents with. But I think if the patient has a VUS in some sort of gene that you don't know, then I think we would certainly have to look that up and see what the disease it's associated with, what pathway it's associated with, and then come to some sort of judgment as to whether we think it may be responsible for the phenotype or at least partially responsible.
Before we wrap up, I was hoping that you could give us a little insight into some of the more frequent errors made by rheumatologists, because I want to get a little bit of a head start on what things am I probably routinely getting wrong. Do you have is there anything common that you're seeing?
I wouldn't say that these are necessarily things that rheumatologists are getting wrong, but I think the medical community in general, I think it's a challenge because a lot of the medical community in general are not very aware of autoinflammatory disorders. And so many of these patients are missed for a long time. And autoinflammatory disorders, I like to think of them really just like any other rheumatologic disorder, which is a burning candle. And, what happens when you have a burning candle is you have a flame at the top, the candle gets hot, and the candle starts to drip wax, and then you end up with more and more wax that pools at the bottom. And so our job, I think, is to recognize the candle, see the burning flame quickly so that we can put out the flame quickly before the standing candle becomes a puddle of wax. Because when the candle becomes a puddle of wax, you no longer have any active inflammation that you can really modify, and you're dealing with a chronic sort of phenotype with a lot of chronic pain and disability that is very difficult to treat. And so I think recognition is probably the most important part in this whole story. And I would just say that one thing that I would like to see more of is just earlier recognition and earlier referrals. I think a lot of my colleagues have often said they've given me referrals and said, I don't know if this is an appropriate referral. I don't know if this is probably just way left field. It's probably not an autoinflammatory disorder, but I don't know what we're dealing with here. And if you don't think it's an autoinflammatory disorder, that's fine. You don't have to see it. I get a lot of these referrals. And I will say that 95+% of the time, my response is, this is an excellent referral. I think this is a great case and it should have been seen much earlier. So I think when in doubt, make the referral. Find your provincial autoinflammatory specialist and make friends with them and just run the cases by them, because the worst they can say is no. But I think most of the time they're going to say yes.
I think, Jason, that also tells us like this is a really evolving field. And certainly when I first started practice, we only saw the autoinflammatories kids that were almost many of them no longer were symptomatic, or the FMFs that transitioned into adulthood with the occasional systemic onset adult. So the occasional adult onset Still's disease. And now I think my eyes are very open that there's a big spectrum. And way back, it was steroids, colchicine, and then we would use methotrexate because that's what we had. And then when the TNF came, it was a TNF. So it's come a long way now that we have IL-1s and IL-6 inhibition. We have some things that are a bit more helpful in interferonopathies. So I guess when we're not really sure for a treatment perspective, a lot of these times, if we want to put the candle out fast because it's really hot, we're probably going to give glucocorticoids in this adult while we're snooping around and trying to be holistic to say asking chat in a way. Okay, they have conjunctivitis, they have oral ulcers, and they have these other things. And I suspect give me a differential. And I think that has actually really helped me, and because then I'm going to go a little bit more directed on treatment, because it is difficult for adults, for most of us, to get coverage right away in a rare disease that is difficult to prove, as you say, the VUS, the variant of uncertain significance. And usually these people, at least the ones that I might see, because I have a heavy connective tissue disease practice, but they've been through, as you said, allergy, but a lot of them have been through a couple of ID specialists. If they have high CRPs and fevers, even if the fevers aren't high, they get a lot of other things done. Jason, if you were going to say, okay, here's the lesser rare ones of adult onset, do you have a quick algorithm of, okay, I might use glucocorticoids and then what? Are you already trying to distinguish whether they're in one of the 4 buckets, or are you just going down an algorithm of here's what I can obtain tomorrow for treatment?
Yeah, that's a really good question. And I think it really depends on the phenotype. If the phenotype is really severe and we're dealing with a life-threatening situation, then you're going to have to throw what you can at the problem. And that tends to be IV steroids and perhaps anakinra and perhaps IV Remicade or things like that. But I generally take a step back, because most of these patients have been dealing with their condition for many years. And I think of the therapies that we have also as diagnostic tools. And so I will usually try to pick therapies that have a relatively narrow window of effect in terms of the pathways that they target, as a tool to try to narrow down the pathway that we're dealing with. And so I tend to start with colchicine because that tells me whether we may be dealing with an IL-1 type of disorder or a cytoskeleton type of disorder. And then perhaps IL-1, and then TNFs and JAK inhibitors and so on. I try not, unless they are a clear-cut P-FAPA type of patient, where we know that most of them are polygenic and will respond really well to steroids. I tend not to start them on steroids right away, because I know for sure that they probably will respond, but then I don't really know what I'm dealing with.
Okay, maybe we'll leave it there, unless, Jason, did you think that there were any burning questions that you really would like to address before we wrap?
I think the last thing that I'll say is the autoinflammatory disorders come from the innate immune system, which have been around for over 100 million years. And so the autoinflammatory diseases are not new, although the field of autoinflammation is relatively new. And so I think we're learning a lot. We've learned a lot in the past couple of years, and we have a lot more to learn. And I'm really looking forward to the next few decades. I think it's going to be really exciting for the field, and I look forward to seeing a lot of interesting patients with you guys.
Dr. Jason N., thank you so much for chatting with us today. That was really interesting and a really helpful discussion of evolving and complicated topics. So thank you very much.
And you've opened my eyes more, so that's really helpful.
Thank you very much for having me, and I'm looking forward to seeing you guys at the CRA.
Absolutely.
Absolutely. We'll be broadcasting there, we hope.
That's it for this episode of Around the Rheum. For questions, comments, and future episode ideas, email us at info@rheum.ca. Around the Rheum is produced by David McGuffin, Dr. Dax Rumsey, and Aaron Stewart. We would like to give a special thanks to the Communications Committee and the staff of the CRA for their hard work. And of course, an extra special thanks to our guest, Dr. Jason N. Our theme music was composed by Aaron Fontwell. If you enjoyed your time with us, please give us a rating and review where you listen. It helps others to find these episodes. And be sure to subscribe so you don't miss future episodes. With Janet Pope, I'm Daniel Ennis. Thanks so much for listening.